the real cause of high blood pressure and how to fix it, doctor explains. It is a sobering reality that high blood pressure affects nearly half of all American adults, approximately 122 million people, a staggering statistic from the American Heart Association. Even more concerning is that 75% of these individuals rely on medication to manage their condition. Yet, despite faithful adherence to prescriptions, medication often falls short of truly controlling the disease, as evidenced by the tragic fact that over 675,000 Americans succumb to hypertension-related complications each year. Dr. Michael Kent, drawing upon more than 2 decades of experience performing cardiac surgery, offers a profound explanation for this widespread failure. The conventional understanding of high blood pressure is fundamentally incomplete and outdated. Patients are often told that hypertension is merely a plumbing issue, a problem of excessive fluid volume within the circulatory system, leading physicians to recommend sodium reduction and diuretics to expel excess water. While these interventions might temporarily lower pressure readings, creating an illusion that the problem is solved, Dr. Kent emphatically states this entire framework is based on medical thinking from 50 years ago, proving incomplete, misleading, and keeping millions sick despite seemingly controlled numbers on their monitors. The true reality of hypertension is far more intricate and complex. It is not merely a plumbing problem concerning volume, but rather an issue rooted in the integrity of the pipes themselves, your arteries. These vital vessels are not simply overfilled. Instead, they are damaged, deteriorating, and rigid, having undergone significant structural changes at the cellular level that no prescription medication can genuinely repair. When Dr. Kent performs bypass surgery, directly opening someone's chest, he observes this damage firsthand. A healthy artery possesses natural elasticity, springing back when incised, whereas a diseased artery from someone with chronic hypertension is disturbingly stiff, calcified, and rigid, feeling almost like cutting into bone. This very rigidity, he explains, is the true essence of hypertension, and critically, medications do not fix this underlying stiffness. They merely manipulate the pressure reading displayed on a monitor without addressing deeper structural damage. However, there is a path to genuine reversal, and by understanding 4 hidden mechanisms that contribute to hypertension, individuals can embrace a complete 4-step protocol designed to repair this damage at a fundamental structural level, drawing upon cellular biology and biochemistry. To begin, a deeper understanding of hypertension at the cellular level is essential. Your arteries are exquisitely complex living structures, meticulously composed of 3 distinct layers. The innermost layer, known as the endothelium, forms the delicate surface that directly interacts with your flowing blood. This layer, a single sheet of cells thinner than tissue paper, lines every blood vessel throughout your body and is absolutely indispensable. Far from being a mere physical barrier, the endothelium is an active metabolic organ, diligently producing intricate chemical signals that govern blood flow, prevent inappropriate clotting, regulate inflammation, and maintain overall vessel health. Protecting the endothelium itself is a microscopic layer called the glycocalyx, often likened to a non-stick coating on the interior surface of your arteries. This vital coating is meticulously constructed from sugar molecules and proteins, measuring only a few micrometers thick, thus remaining invisible to the naked eye. Yet it stands as one of the most profoundly important structures within your cardiovascular system. Pivotal research published in Pfluger's archive in 2007 unequivocally established several critical functions performed by the glycocalyx. Firstly, it creates an exceptionally smooth, frictionless surface, enabling blood to flow effortlessly and without resistance. Secondly, it acts as a crucial barrier, preventing inflammatory molecules from reaching and detrimentally attaching to the delicate vessel wall. Thirdly, it possesses the remarkable ability to sense subtle changes in blood flow, subsequently signaling the endothelium to release nitric oxide, a crucial gas molecule that ensures vessels remain relaxed and appropriately dilated. When your glycocalyx remains perfectly intact and healthy, your vessels retain their natural flexibility and optimal function. Conversely, when this vital coating becomes damaged and begins to break down, the entire system can unravel. Factors such as elevated blood sugar levels, chronic systemic inflammation, cigarette smoking, and oxidative stress mercilessly strip away the glycocalyx, much like acid dissolving a protective coating. Once this critical layer is compromised or gone, your vessel wall becomes dangerously exposed and vulnerable. Inflammatory molecules circulating in your bloodstream then readily attach to the now exposed endothelium. White blood cells adhere to the compromised wall, and harmful LDL cholesterol particles are able to penetrate deep into the vessel tissue, initiating the insidious formation of atherosclerotic plaque. Simultaneously, the damaged endothelium significantly curtails its production of adequate nitric oxide, leading your vessels to constrict and lose their essential flexibility, causing blood pressure to climb inexorably. This cascade constitutes the first fundamental mechanism of hypertension: glycocalyx destruction and endothelial damage. The critical point here is that no existing blood pressure medication is capable of repairing the glycocalyx. ACE inhibitors, beta blockers, calcium channel blockers, and diuretics all fail to address this root cause. While they may effectively manage the pressure reading on your monitor, the underlying damage to this protective layer remains untreated. Therefore, even if your blood pressure numbers appear controlled with medication, your vessels are still structurally damaged, acutely vulnerable, and silently progressing towards a potentially devastating stroke or heart attack. This disparity precisely explains why individuals on blood pressure medication continue to experience cardiovascular events. The medication treats the symptom, but not the true underlying cause. This brings us directly to the second pivotal mechanism: arterial stiffness and calcification, a critical aspect most physicians regrettably overlook. Their focus remains almost exclusively on blood pressure numbers, neglecting the far more significant distinction of whether arteries are stiff or flexible, a distinction that often matters more than the numerical readings themselves. Groundbreaking research published in the Journal of the American College of Cardiology in 2010, through a systematic review and meta-analysis, conclusively demonstrated that arterial stiffness is a superior predictor of cardiovascular events and all-cause mortality compared to traditional blood pressure measurements alone. Blood pressure is conventionally measured as two numbers: systolic over diastolic. The difference between these two numbers, known as pulse pressure, provides crucial insights into arterial stiffness. A normal pulse pressure typically ranges between 40 and 50. However, as arteries stiffen due to factors like aging and disease, systolic pressure tends to increase, while diastolic pressure concurrently decreases. For instance, an individual might present with a blood pressure of 162/72, where the systolic is elevated and the diastolic is low, resulting in a wide pulse pressure of 90. Any pulse pressure exceeding 65 strongly indicates that the arteries are stiff and calcified, signifying that the aorta has lost its vital elasticity and shock-absorbing capacity. A comprehensive 2006 expert consensus document published in the European Heart Journal further established that arterial stiffness can be directly and objectively measured using a non-invasive test called pulse wave velocity. This test precisely quantifies how rapidly a pressure wave propagates through your arterial system. In healthy, flexible arteries, this wave travels relatively slowly, typically around 6 to 7 meters per second. Conversely, in stiff, diseased arteries, the wave travels much more rapidly, often reaching 12 to 15 meters per second. The faster the wave velocity, the stiffer your arteries, and consequently, the higher your cardiovascular risk. Despite its ready availability and non-invasive nature, taking only about 10 minutes to perform, almost no physicians routinely order this crucial test. The underlying reason: there is no prescription medication that directly addresses or fixes arterial stiffness. Research published in the American Journal of Hypertension in 2004 explicitly elucidated the implications of vascular stiffening for systolic blood pressure, noting that current pharmaceutical approaches don't address the underlying structural problem. To fully grasp the cause of arterial stiffness at the tissue level, one must understand the artery wall's three distinct layers. The crucial middle layer, termed the tunica media, is composed of specialized smooth muscle cells and elastic fibers, which are responsible for endowing your arteries with their essential flexibility and their capacity to expand and contract. However, with advancing age, and particularly in the presence of hypertension, diabetes, or chronic inflammation, several destructive processes relentlessly compromise this vital middle layer. Firstly, calcium deposits begin to form. While calcium rightly belongs within your skeletal system, when vessels are subjected to chronic inflammation, calcium aberrantly migrates from your bloodstream directly into the tunica media. There, it crystallizes and forms increasingly rigid deposits, making the vessel wall progressively less pliable. Secondly, the vital elastic fibers gradually break down and degrade, being slowly but inexorably replaced by collagen, a substance that is inherently stiff and inflexible. Thirdly, the smooth muscle cells themselves undergo a pathological transformation, ceasing to function as proper muscle cells and instead beginning to behave more like bone-forming cells, actively depositing calcium and thereby accelerating the calcification of the vessel wall. A comprehensive review published in the Journal of the American College of Cardiology in 2019 definitively established that this multifaceted process, known as vascular calcification, is the primary driver of arterial stiffness and a significant amplifier of cardiovascular risk. By the time an individual reaches 65 years of age, especially after years of poorly controlled hypertension, their arteries can come to resemble bone tissue more than actual blood vessels, calcified, rigid, and utterly inflexible. Importantly, no existing blood pressure medication is capable of reversing this profound process. ACE inhibitors do not remove calcium deposits from vessel walls. Calcium channel blockers, while useful for acutely relaxing smooth muscle cells by blocking calcium entry, do not remove the calcium already intricately embedded within the structural wall. The calcification stubbornly remains, and the stiffness relentlessly persists. Therefore, the crucial question arises: can arterial calcification actually be reversed? The answer, unequivocally, is yes, but not through prescription medications. Rather, it requires specific, targeted nutritional interventions that most physicians, unfortunately, have never been formally educated about. The third mechanism contributing to hypertension is nitric oxide deficiency. Nitric oxide, NO, is an extraordinary gas molecule meticulously produced by your endothelial cells. Research published in the European Heart Journal in 2012 firmly established nitric oxide as one of the most profoundly important signaling molecules within your entire cardiovascular system. When nitric oxide is appropriately released from the endothelium, it readily diffuses into the smooth muscle layer of your vessel walls, sending vital signals to these muscle cells to relax. As a direct consequence, your vessels dilate, allowing blood to flow far more easily, resistance drops significantly, and blood pressure naturally decreases. Healthy, functionally robust endothelium continuously produces nitric oxide, thereby maintaining vessels in a relaxed state and preserving normal blood pressure. However, when your endothelium becomes damaged, particularly when the protective glycocalyx is stripped away, nitric oxide production plummets dramatically. This impairment means your vessels cannot relax properly. Instead, they remain constricted, causing blood pressure to rise and stay stubbornly elevated. The specific enzyme responsible for producing nitric oxide is called endothelial nitric oxide synthase, or ENOS. This crucial enzyme is unfortunately damaged by the exact same factors that compromise the glycocalyx: elevated blood sugar, oxidative stress, and chronic inflammation. For ENOS to function optimally and produce nitric oxide efficiently, it requires several essential cofactors, with the most critical being a molecule known as tetrahydrobiopterin, or BH4. When BH4 levels are adequate, NOS performs its function effectively. However, when BH4 becomes depleted, ENOS becomes dysfunctional, paradoxically producing harmful free radicals instead of beneficial nitric oxide. The ENOS enzyme is also ingeniously activated by shear stress, which is the mechanical friction generated as blood flows across the endothelial surface. When blood flow increases, this friction stimulates ENOS, which is precisely one of the key reasons why regular exercise demonstrably lowers blood pressure. A 2014 meta-analysis published in Sports Medicine meticulously examined the role of isometric exercise training in reducing blood pressure and identified its potential mechanisms. The research revealed that isometric resistance training, which involves contracting muscles without any discernible movement, is particularly effective. A specific protocol studied involves squeezing a hand grip device at 30% of maximum strength for a duration of 2 minutes, followed by a 1-minute rest, and then repeating this cycle 4 times. This exact protocol has been robustly demonstrated in multiple clinical studies to lower systolic blood pressure by an impressive 8 to 12 points after just 8 weeks of consistent practice. Finally, we arrive at the fourth and equally critical mechanism, the insulin-kidney connection. This profound connection elegantly explains why merely reducing sodium intake often proves ineffective for the vast majority of individuals grappling with hypertension. Your kidneys are the master regulators of blood pressure, primarily by meticulously controlling sodium balance within your body. However, this intricate system is entirely dependent on your kidney's inherent ability to respond appropriately to varying sodium intake. Herein lies the critical problem. Insulin fundamentally blocks sodium excretion from the kidneys. When insulin levels are chronically elevated, a common occurrence in many modern diets and lifestyles, your kidneys stubbornly retain sodium regardless of how little you might be consuming. Landmark research published in the New England Journal of Medicine in 1987 definitively established that insulin resistance is not only prevalent in essential hypertension, but also plays a direct causal role in the elevation of blood pressure. Insulin exerts its influence on the kidneys through several distinct pathways. Firstly, it directly stimulates sodium reabsorption in the proximal tubule of the nephron, meaning more sodium is reabsorbed back into the bloodstream and less is excreted in the urine, leading to increased sodium retention. Secondly, insulin actively stimulates the sympathetic nervous system, prompting your kidneys to release renin, which then triggers a complex hormonal cascade, culminating in the release of aldosterone. Aldosterone, in turn, specifically instructs your kidneys to retain sodium while simultaneously excreting potassium. Thirdly, insulin increases the sensitivity of your blood vessels to angiotensin II, a potent vasoconstrictor, further contributing to elevated blood pressure. A landmark 1991 paper, published in Diabetes Care, definitively established that insulin resistance is a multifaceted syndrome underlying not only hypertension, but also obesity, dyslipidemia, and atherosclerotic cardiovascular disease. This comprehensive understanding explains precisely why individuals with insulin resistance, prediabetes, or full-blown type 2 diabetes almost invariably develop hypertension. The chronically elevated insulin levels essentially lock their kidneys into a continuous sodium retention mode. What most people fail to realize is that one can exhibit significant insulin resistance without yet having a diagnosis of diabetes. Your fasting blood glucose might appear completely normal, and your hemoglobin A1C might also fall within the normal range. Yet your insulin levels could be substantially and dangerously elevated, silently driving your hypertension. Regrettably, most physicians do not routinely check insulin levels. They typically only assess glucose and A1C, and if these are normal, they erroneously assume insulin is also fine. This assumption is incorrect. Having illuminated these 4 underlying mechanisms, we can now present the complete 4-step protocol designed to genuinely reverse them. The first step focuses on restoring the glycocalyx. Initially, you must cease the destructive processes. The primary culprits for glycocalyx damage are elevated blood sugar and oxidative stress. Each instance your blood sugar spikes above 145 mg DL, it inflicts damage through a process known as glycation. Therefore, the foundational first part of this step is stabilizing your blood sugar, not merely to avoid diabetes, but to consistently maintain your post-meal blood sugar levels below 140 mg DL. For most individuals, this critically entails significantly reducing refined carbohydrates. This doesn't necessitate eliminating all carbohydrates, but rather making conscious choices for carbohydrates that do not dramatically spike blood sugar, such as whole foods, non-starchy vegetables, legumes, and certain fruits, while actively avoiding refined sugar, white bread, white rice, pasta, and baked goods. Secondly, you must actively provide your body with the necessary building blocks to painstakingly rebuild the glycocalyx. This delicate coating is primarily constructed from molecules called glycosaminoglycans, which are long chains of sulfated sugar molecules. The most effective dietary sources for these are sulfated polysaccharides derived from seaweed, particularly fucoidan from brown seaweed. Research has consistently demonstrated that these compounds can effectively restore glycocalyx thickness and significantly improve endothelial function. Supplements containing fucoidan are readily available, with studies showing benefit using doses ranging from 600 to 1,000 milligrams daily. Thirdly, it is imperative to significantly reduce oxidative stress. The most potent antioxidants crucial for vascular health are the diverse polyphenols found abundantly in colorful vegetables and fruits, including berries, dark leafy greens, beets, dark chocolate, and green tea. These foods are rich in compounds that powerfully neutralize free radicals before they can inflict damage upon your precious glycocalyx. Consider an illustrative case, a 71-year-old individual with hypertension for 13 years, taking 2 medications, whose blood pressure was controlled at 130/82, but whose lab tests revealed elevated markers of endothelial dysfunction. Upon initiating a protocol that involved eliminating all refined carbohydrates, adding an 800 mg daily fucoidan supplement, and dramatically increasing polyphenol-rich foods, including a cup of mixed berries and 2 cups of leafy greens daily, remarkable improvements were observed. After just 12 weeks, endothelial function tests showed dilation improved significantly from 5% to 13%, and blood pressure dropped from 130/82 to an impressive 116/74. This individual was able to reduce 1 medication after 6 months and was entirely off both medications after 12 months, with blood pressure stable at 120/76. The second step is decalcification, the crucial process of actively removing calcium from your artery walls and thereby restoring their natural flexibility. Many wrongly assume that once calcium deposits form in arteries, they are permanent and irreversible, but this belief is mistaken. The key protein involved in this process is called matrix GLA protein, or MGP. This protein functions as a critical traffic controller for calcium. When MGP is properly activated, it precisely directs calcium into your bones, where it rightfully belongs. Conversely, when MGP is not activated, calcium errantly migrates into your arteries and precipitates as deposits within the vessel walls. MGP is specifically activated by vitamin K2, particularly its MK7 form. Research published in Atherosclerosis in 2009 revealed that a high dietary menaquinone, vitamin K2, intake is strongly associated with reduced coronary calcification. Furthermore, the esteemed Rotterdam study, published in the Journal of Nutrition in 2004, firmly established that dietary intake of menaquinone is associated with a significantly reduced risk of coronary heart disease. Without adequate vitamin K2, MGP remains inactive, allowing calcium to deposit freely and damagingly in your arteries. With adequate vitamin K2, MGP becomes activated, efficiently redirecting calcium out of your arteries and into your bones. This powerful process can indeed actively reverse arterial calcification. Studies demonstrating significant benefit typically utilize doses of 180 to 360 micrograms daily of MK7. However, vitamin K2 is only one part of this multifaceted solution. Calcium also critically requires vitamin D to effectively enter bone tissue. Vitamin D increases calcium absorption from your digestive tract and plays a vital role in incorporating calcium into the bone matrix, highlighting the need for both vitamins to work synergistically. The third essential component in this decalcification strategy is magnesium. Magnesium can be thought of as nature's own natural calcium channel blocker. When magnesium levels are adequate, it effectively blocks calcium from inappropriately entering the smooth muscle cells within vessel walls. When magnesium is deficient, calcium floods into smooth muscle cells, causing vessels to constrict and blood pressure to rise. Magnesium also crucially prevents calcium from crystallizing and forming detrimental deposits in vessel walls. A significant portion of the population is deficient in magnesium, largely because its primary dietary sources are dark leafy greens, nuts, seeds, and whole grains, which are often lacking in modern diets. Moreover, several factors actively deplete magnesium, including chronic stress, alcohol consumption, diuretic, medications, and proton pump inhibitors frequently used for acid reflux. The solution lies in magnesium supplementation, utilizing highly absorbable forms such as magnesium glycinate or magnesium threonate, which are efficiently assimilated by the body. A beneficial dose for cardiovascular health typically ranges from 400 to 600 milligrams daily. Consider another illustrative scenario: a 74-year-old individual with hypertension for 18 years, taking 4 medications whose blood pressure was barely controlled at 136/86. A CT scan revealed severe calcification throughout their aorta. Upon embarking on a decalcification protocol, which included vitamin K2 at 360 micrograms daily, vitamin D at 6,000 international units daily, and magnesium glycinate at 600 mg daily, remarkable progress was noted. After just 6 months, a repeat CT scan showed the calcification score had decreased by an impressive 9%. Blood pressure dropped to 122/78, enabling a reduction from 4 medications to 3. After 1 year, the calcium score had decreased by 16%, and after 18 months, the individual was on only 1 medication with excellent blood pressure control. The third step focuses on nitric oxide restoration. Firstly, it is crucial to protect and boost BH4, the critical cofactor for the eNOS enzyme. This involves ensuring adequate intake of folate, vitamin C, and vitamin E, as these essential vitamins help regenerate BH4 and prevent eNOS uncoupling, where it produces harmful free radicals instead of beneficial nitric oxide. Folate can be obtained from dark leafy greens, vitamin C from citrus fruits, berries, and bell peppers, and vitamin E from nuts and seeds. Research published in the Journal of Cardiovascular Pharmacology in 1999 demonstrated convincingly that oral vitamin C significantly reduces arterial stiffness in humans. Secondly, it is vital to stimulate eNOS through shear stress. The most effective method for this is isometric hand grip training. This involves squeezing a hand grip device at 30% of your maximum strength for 2 minutes, resting for 1 minute, and repeating this sequence 4 times, ideally 4 times per week. Thirdly, adopting nasal breathing practices is highly beneficial. When you consciously breathe through your nose instead of your mouth, your nasal passages naturally produce nitric oxide. Studies have compellingly demonstrated that nasal breathing can increase blood nitric oxide levels by up to 400% compared to mouth breathing. The fourth and final step is the insulin reset. This vital step is designed to unlock your kidneys, allowing them to effectively excrete sodium as they are naturally intended to do. As previously explained, chronically elevated insulin locks your kidneys into a persistent sodium retention mode. Therefore, you must proactively work to lower your insulin levels. The most effective method for achieving this is time-restricted eating, also commonly known as intermittent fasting. This involves condensing all your food intake into a specific window each day and abstaining from calories during the remaining hours. For individuals with hypertension, a recommended protocol is a 16-hour fast with an 8-hour eating window. This typically translates to consuming all meals between noon and 8 p.m., and then fasting from 8 p.m. until noon the following day. During the fasting window, only water, black coffee, or plain tea without added calories should be consumed. Research consistently demonstrates that time-restricted eating can lower systolic blood pressure by an impressive 9 to 11 points within just 8 weeks, notably without any change in what you eat, but purely by regulating when you eat. The underlying mechanism is entirely insulin-related. Lower insulin levels translate to unlocked kidneys, which in turn leads to appropriate sodium excretion and ultimately normalized blood pressure. Furthermore, you must actively reduce insulin resistance at the cellular level. The most effective way to significantly improve insulin sensitivity is through consistent resistance training. When you engage in resistance exercises, your muscles develop more insulin receptors, making them more responsive to insulin. Studies have shown that performing resistance training 2 to 3 times weekly can lower fasting insulin by 20 to 30% within 12 weeks. This comprehensive approach is what genuinely reversing hypertension looks like. It is not merely managing symptoms temporarily or controlling numbers with a regimen of pills, but rather fundamentally fixing the underlying mechanisms permanently. The core components are glycocalyx restoration, arterial decalcification, nitric oxide production, and insulin normalization. These 4 interconnected steps directly address the actual root causes of hypertension. When these root causes are effectively addressed, blood pressure naturally normalizes, as your body possesses an innate capacity to heal itself when provided with the correct conditions and support. Individuals can begin by choosing the step that resonates most with them or addresses their most apparent issue. For instance, if one consumes a diet rich in refined carbohydrates and sugary foods, starting with glycocalyx restoration by stabilizing blood sugar would be a logical first step. If there are signs of being overweight or having insulin resistance, initiating the insulin reset through time-restricted eating would be highly beneficial. If exercise is a rarity, commencing with nitric oxide restoration via isometric training would be an excellent starting point. It is crucial to emphasize that discontinuing blood pressure medication abruptly is dangerous. Medications manage symptoms while these protocols diligently work to fix the root causes. Initially, both approaches are needed. Individuals should begin implementing these protocols while faithfully continuing their current medication regimen. As blood pressure consistently improves over weeks and months, a collaborative approach with a physician is paramount to gradually reduce medication under careful supervision. Daily home blood pressure monitoring to track trends is essential. Once numbers consistently improve and remain stable, discussing medication reduction with your doctor is appropriate. Never stop medication suddenly or reduce doses without direct medical supervision. However, it is equally important not to passively accept the belief that medication will be a lifelong necessity. Conventional medicine, in many instances, has not been equipped with the knowledge or tools to reverse vascular damage. Its primary focus has been on temporarily managing pressure readings. But now, armed with this information, you know differently. You understand the profound significance of the glycocalyx, the process of arterial calcification, the role of nitric oxide, and the intricate insulin-kidney connection. You comprehend the mechanisms at play, and when you understand these mechanisms, you gain the power to correct them. This critical distinction separates mere managing from true reversing. Managing typically implies pills for life, whereas reversing signifies structural repair at the fundamental cellular level. These four interconnected mechanisms are the true architects of hypertension, and standard medical care, unfortunately, does not effectively address any of them directly. Pills temporarily manipulate pressure without repairing the underlying damage, but crucially, you possess the capacity to repair that damage. Glycocalyx restoration can be achieved through blood sugar control, the strategic inclusion of sulfated polysaccharides, and potent antioxidants. Decalcification is possible with the synergistic action of vitamin K2, vitamin D, and magnesium. Nitric oxide restoration is enhanced through sheer stress exercise and conscious nasal breathing. Finally, the insulin reset is accomplished through time-restricted eating and consistent resistance training. When you diligently reverse these fundamental mechanisms, blood pressure normalizes not because it is being artificially forced down by medication, but because your vascular system has been genuinely repaired at its foundational level. This information, often overlooked or not fully grasped by most physicians, is now at your disposal. It is information that holds the potential to liberate you from lifelong medication and to prevent you from becoming one of the 675,000 Americans who tragically succumb to hypertension complications each year. Use it, implement it, start today. Dr. Kent is committed to sharing surgical knowledge and profound insights that could potentially keep individuals out of his operating room. Take diligent care of your vessels, for they are the only ones you will ever truly have. Hypertension is not a permanent life sentence. It is, in fact, a reversible condition, provided you are willing to deeply understand its mechanisms and commit to the dedicated work required to correct them. The choice ultimately is entirely yours. Choose reversal over management.